Thank you so much. What a privilege it is to be able to join you from around the world. And I always enjoy listening to Dr. Tafari, although he is a very, very difficult act to follow because he's so informative. I'm going to talk about the emerging role of molecular signatures in choice of therapy for myelodysplastic syndromes. I'll start off talking about MDS diagnosis and risk, talk about molecular mutations and risk, treatment implications for those mutations, and then I will try to draw some conclusions from all of this information. We'll talk about MDS diagnosis and risk. Well, recently we had revisions in how we classify the myelodysplastic syndromes, and those revisions didn't always agree with each other. So it's left a lot of our field in a little bit of confusion. This is the latest version of the World Health Organization classification for myelodysplastic syndromes. And you can see it's divided into patients who have MDS with a defining genetic abnormality, specifically a deletion 5q abnormality. That isn't new, that's been in World Health Organization classifications for some time. Those patients who have an SF3B1 mutation, specifically the SF3B1 mutation hasn't been singled out in previous versions of the WHO, although patients with ring sideroblasts have been, so this echoes the morphology. And patients with a biallelic TP53 mutation are specifically identified and obviously have a very poor prognosis. Then there's a separate category for MDS that's defined morphologically, including those patients who have fewer than 5% blasts, those who have increased blasts, either 5 to 9% blasts or 10 to 19% blasts. So that again echoes the previous version of the World Health Organization classification. And then there are patients who have hypoplastic MDS or those who have MDS with fibrosis in the bone marrow. Now, the ICC has classified MDS slightly differently. They too identify MDS with an SF3B1 mutation, and those with a deletion 5q abnormality don't call out those patients specifically with a TP53 abnormality, do recapitulate what was seen before in patients who have single lineage or multi-lineage dysplasia, identify those who have excess blasts, but now for the first time had a category of an overlap of MDS and AML for those patients who have greater than to have 10% blasts or greater, which is something that clinically and biologically actually we think makes a lot of sense. So what we can see in the genetic definition of MDS are patients who have a deletion 5q abnormality, an SF3B1 mutation, and in the World Health Organization classification, those who have a TP53 abnormality. Now, we don't have technically a staging system for myelodysplastic syndrome. So what we do instead is use the revised International Prognostic Scoring System. And what this does is basically reflects what we see clinically and what should be pretty intuitive clinically. So patients who come into our clinics and have very poor risk cytogenetics, let's say those who have more than 3 abnormalities, patients who have a high blast percentage, let's say 18% blasts, and those who have multiple cytopenias are going to have a median survival that's measured in less than a year. On the other hand, patients who come into our clinics and have very good risk karyotype, like a -Y mutation, have a low blast percentage, let's say 1% blasts in the bone marrow, and have maybe just an isolated cytopenia, have a median survival that may be measured in almost a decade. Here are the curves for the different classification groups within the revised IPSS. You can see that patients who have lower risk disease have a score of 3.5 or lower, and those with higher risk disease have a score that's greater than 3.5. But you will notice that the revised IPSS does not consider mutations. So it has limitations in the modern era when we're looking for mutations in all of our patients. So how have mutations been incorporated in thinking about risk of myelodysplastic syndromes? Well, mutations in and of themselves carry a certain amount of risk. There are a lot of mutations that have been identified in patients who have myelodysplastic syndromes. You can probably count over 100. Probably about 20 to 25 of those mutations are seen in over 90% of patients, however. Those patients who have an SF3B1 mutation have a very good risk, whereas patients who have any other mutation have either an intermediate risk or poor risk disease, with a particularly poor risk mutations, including those with RAS mutations, RUNX1, ASXL1, TP53, BCOR, etc. So how do we incorporate these mutations into systems that look at pathology, morphology, and clinical characteristics? This was an artificial intelligence machine learning approach that we use, which was published in the Journal of Clinical Oncology within the past year, that looked at patients who were seen, at the time I was at Cleveland Clinic, I'm now at Miami, and patients who were seen in the Munich labs, and this was validated against patients who were seen at the Moffitt Cancer Center in Tampa. Almost 1,500 patients were in our training cohort, and over 800 were in the validation cohort, and these patients looked as if they were fairly typical of those with MDS, with a median age of about 70 years old and a variety of cytopenias and blast percentages. Using this system, we reached an accuracy that was much higher than we saw with the IPSS or revised IPSS, even when mutations were incorporated into those systems. So a system like this, using artificial intelligence or machine learning programming, is complicated enough that data have to be entered online to calculate a score. Now, the IPSS-M was recently published. This was based on data in almost 3,000 patients and validated in a cohort from Japan of 750 patients. Median age of patients included in this was 72 years, and about 1/3 of patients were actually treated with disease-modifying agents. There were 48 genes that were mutated in greater than 1% of patients, the most common of which are those we often see in myelodysplastic syndromes, things like TET2, DNMT3A, ASXL1, SF3B1, deletion 5q, etc. And patients had a median of 4 mutations. This was analyzed using the Cox multivariable regression model that looked at confounder variables, clinical parameters, and IPSS-R cytogenetic categories in addition to the mutations. And this generated curves that had nice separation between them as well. Once again, this is a system where data have to be entered, and a lot of data have to be entered online to calculate a final score and a final prediction of how long a patient is going to live, how long they're going to live without leukemia, and their AML transformation rate. Okay, so what are the treatment implications for these mutations? Well, there are a few of them. These are data from the study that led to the FDA approval of luspatercept. This was FDA approved in patients who had ring sideroblasts, particularly those who had SF3B1 mutations. And you can see a transfusion independence response rate here of 38%, 38% for those who received luspatercept versus 13% for those who received placebo, for an absolute difference of 25%. There does seem to be some specific responsiveness in patients who have SF3B1 mutations or its morphologic counterpart, ring sideroblasts, to luspatercept, and the median duration of response was about 31 weeks. So SF3B1 mutations in and of themselves can be a reason to start a drug like luspatercept in patients who are anemic. Now, this is a trial of the drug imetelstat, which is a telomerase inhibitor. It was published in JCO a couple of years ago. This doesn't have any particular responsiveness in a molecular subtype, but I wanted to show this slide because in it demonstrates that patients who had measurable SF3B1 mutations at the beginning of the trial actually had a reduction in the variant allelic frequency of those SF3B1 mutations on the drug. I think what this reflects is the fact that we can look at mutations and reduction in mutation variant allelic frequency as a marker of response and probably disease modifying response to new drugs that are used in MDS. This is not a new concept. years ago. This is a study we published where we looked at mutations along methylation pathways, so TET2 to NMT3A, IDH1, and IDH2, and looked at whether they were more predictive of a patient having a response to a hypomethylating agent. And in fact, it looked like they were. Patients who had one of these mutations were more likely to respond to a hypomethylating agent than those patients who didn't have one of these mutations. This was also shown by Raphael Behar in the same year, where patients who had a TET2 mutation looked as if they were more likely to respond to hypomethylating agents unless they had a concomitant ASXL1 mutation, in which case they were less likely to respond. So time and again, we've shown that patients who have mutations along methylation pathways seem to have a higher likelihood of responding to hypomethylating agents, but we've also shown time and time again that does not necessarily translate to an improvement in overall survival in these patients. Sorry. So another way of looking at this again is to focus on artificial intelligence, machine learning programming in patients who are treated with hypomethylating agents to see if there's some characteristic of these mutations that predicts response or lack of response to hypomethylating agents. In this study, you can see on the left of the slide are mutations that were seen in responders, and the relative size of those bubbles is the relative representation of those mutations in responders. On the right are the mutations that were seen in patients who didn't respond to hypomethylating agents. About 1/3 of patients had 3 or more mutations, and the overall response rate to hypomethylating agents in the entire cohort was about 43%. What we found is that those patients who had specific combinations of mutations, like ASXL1, EZH2, and TET2, were much less likely to respond to hypomethylating agents, whereas patients who had the combination of TET2, RUNX1, and SRSF2 were much more likely to respond to hypomethylating agents. So combinations of mutations can also be used to predict response to treatment. Here you see that those patients who had 3 or more mutations and satisfied the rules that we set up for lack of response had a much lower likelihood of responding and a much worse median overall survival than those patients who had fewer than three mutations, or those who had more than 3 mutations and did not satisfy the rules for non-responders. So here's some early data on the combination of azacitidine and venetoclax in patients with higher risk MDS. This shows a good overall response rate. It's a little bit hard to tease out that exact response rate from the data that have been presented, but we see a CR rate here of 40%, which is higher than what we would expect with single agent hypomethylating agents, which falls out around 20%. And some of those marrow CRs had a hematologic improvement. So I think the overall response rate here was probably about 55%. That's what we seem to see in combination therapies in early phase studies. In this presentation by Jacqueline Garcia of venetoclax plus azacitidine in patients with higher risk MDS, we do see that you can measure a reduction in variant allelic frequency of specific molecular mutations in patients who achieved a CR or a marrow CR over time. So once again, I'm not saying that there's a specific mutation that predicts a response to the combination of azacitidine and venetoclax in higher risk MDS, but mutation variant allelic frequency can be measured as an adjunct to response in patients who ultimately do have a clinical response in this disease. Now, the drug APR-246, which restores TP53 activity, has also been studied in higher risk MDS in combination with azacitidine. And in this study, which actually was eventually published in Journal of Clinical Oncology about a year ago, the overall response rate was quite high, approaching 90%. It's hard to look at a duration of response and an overall survival in this population because so many of these patients did undergo eventually a transplant, and we're still waiting on a report out from the randomized study in which, while there was a slight improvement in CR rate from about 22 to 33%, there was no improvement in overall survival in the initial release of the data. So conceptually, this is a really neat idea in a population of MDS patients who don't have a very good survival. In how it's played out so far, this isn't yet an approach we can use to target patients who have a TP53 abnormality. Now, one approach that we have started to use is to focus on IDH2 inhibitors. In the study that led to the approval of enasidenib in patients who had relapsed or refractory AML with an IDH2 abnormality, a total of 17 patients in this study also had myelodysplastic syndromes. And among those 17 patients, the overall response rate was between 40 and 50%. So a lot of these patients are those who've already been exposed to a hypomethylating agent. Once a hypomethylating agent has failed our patients, we really have very few options available of how to treat our patients next. It's nice to know that for patients who have an IDH1 or an IDH2 abnormality, there is the possibility of using drugs like ivosidenib or enasidenib. There were some data that were presented at the American Society of Hematology annual meeting this past year from the GFM group in France, where they also showed a similar response rate of about 40% for patients with IDH2 mutated MDS2 and enasidenib. And here you can see the survival curves for patients who had higher risk MDS and were receiving this as second line therapy, which is where we think it probably fits best, versus those who were receiving this as first line therapy and those with lower risk MDS. So to try to wrap this all up, I think incorporating molecular mutations into risk scoring systems makes prognostication more accurate, and it's the way we're going in the future. We're starting to use targeted therapies in small MDS populations with discrete mutations. These are still largely early phase studies, but I do think we're going to see a role for drugs like ivosidenib and enasidenib after hypomethylating agent failures, and combinations of drugs, for example, hypomethylating agents and an IDH1 or IDH2 inhibitor, as we saw in AML, are also being developed. I want to thank all of you for listening today. What a thrill it is to join you. Our entire Leukemia and MDS group here at University of Miami Sylvester Cancer Center, and most of all, I'd like to thank our patients.